All right, so in the fifth lecture here of the thorax, we're going to go over the pleura. So first, what is the pleura? The pleura is a double membrane or two layers of a serous membrane that envelop the lungs. And you can see it in this diagram here. This is a cross section here of the thorax. Beautiful diagram. Gives you the outer layer, which is this part right here, the parietal layer, and then you have the inner layer, which is the visceral layer here. So you can see that right here, and then there's a space between them called the pleural space. So it's a serous membrane that both pleural layers, they tightly envelop the lung. It's like a fist wrapped in a deflated balloon, you could think of. All right, so just to give you a different view of this in a different plane, so if you have the lung like this, and you have the hilum right here, this is the hilum where the bronchi and the vessels come into the lung, and you can actually see this here. And this is where the fist through the balloon. So the idea is like this would be the wrist, and then the fist would be in here like this, would be the center of the lung tissue. And then the balloon is kind of stretched out. The two layers of the balloon are stretched out around the fist and then end here at the wrist. And so this is kind of more looking at it anteriorly. You have the two layers like this, and they wrap around like this, just like that. So they, terminate here at the hilum. So again, this would be, the hilum would be like the fist coming in through the balloon. So you have the parietal pleura and the visceral pleura. So on this is a great diagram where we show you the different divisions. This side, it just shows you parietal versus visceral. So this is the parietal, this is the visceral, tightly adhering it, and this blue, the red is the parietal. The visceral, there's not really divisions of it. The visceral is the visceral all the way through because it's pretty tightly adherent to the lung, but the parietal has several different divisions through here. So the parietal pleura, it lines the inner surface of the chest cavity and then the outer layer of the mediastinum, which the mediastinum is a region of the thorax where it contains the heart and other structures passing through. Now, the parietal pleura is broken into sections named for the structures they border. So these sections aren't too hard to remember because it's made easy. It's just named for where it's bordered. So you have the mediastinal pleura, which is shown in this blue here. And again, that borders the mediastinum, which is in here. You have the diaphragmatic pleura, which borders the diaphragm, which that makes sense. The diaphragm is at the base of as we talked about, the base of the thoracic cage. So this is the diaphragmatic. It's the inferior portion of the lung that rests on the diaphragm. Then you have the costal pleura, which is shown here in this green here, like this. And that is what wraps around and make contact with the lungs. This is probably one of the larger portions of it. Then you have the cervical pleura, which is shown here in black, and this is also known as the cupula. That's a name for this division or section of the parietal pleura. And as you can see, it's a dome-like section, and it arrives above the first rib here and actually extends into the neck. And by extending the neck, it actually makes it susceptible to injury. So neck injuries can actually affect the pleura because of this cupula. Again, the visceral pleura is shown here. It directly lines and invests the lung tissue, and it has no subsections. All right, so we're going to cut to the skeleton model here for a second, just because the last diagram on the last slide it's a good representation of the borders, but I don't think it gives you a full sense of the three-dimensional aspect of the structure of the pleura. So what we've done here is we've put a piece of white paper here inside the skeleton here to give you a sense of the structure of the parietal pleura. And so this section right here, as you can see, it's all along here. This would be the costal pleura. And really what I want you to take away from this is to understand that costal pleura is not just, one section here. The costal pleura extends three-dimensionally all around the entire aspect of the rib cage. It's a three-dimensional structure. So the costal pleura same thing where the diaphragmatic pleura is not just this section down here. It extends across the whole bottom of the thoracic cage. And then we also showed you a good representation of the cervical pleura up here, which by representing another piece of paper that it extends out above, notice it comes above the first rib, also called the cupula. So let's give you a sense of this structure as well. The innervation of the pleura, it depends on the layer. So the visceral pleura is innervated by the autonomic nervous system, and especially via sensory fibers from the vagus nerve. So you can actually see the vagus nerve traveling in here on this cross section, and then again here's the visceral pleura and the parietal pleura. So the visceral pleura is receiving innervation from this vagus nerve and other autonomic plexi and fibers. the parietal pleura is actually innervated by the somatic nerve. So this is a really important distinction to be made. So visceral layer is autonomic or visceral innervation, and then the parietal layer is somatic. Okay, so what does that mean? So if you remember somatic pain versus visceral pain, somatic pain it's the same kind of pain you would feel if you were to cut yourself or hurt yourself on the outer surfaces. It's localized to dermatomes. It's very specific localized pain is somatic pain. And then visceral pain it's more so referred pain from organs within. So it's not as specific, it's more of a dull, non-specific pain. It can be localized to a certain region, but not as specifically as somatic pain, which is more sharp, localized pain versus dull, non-specific pain for visceral. So the parietal pleura, it's innervated by somatic nerves, and the two somatic nerves to be aware of that are involved are the phrenic nerve and then the intercostal nerves. Phrenic nerve innervates the mediastinal pleura because the phrenic nerve, you can see it right here, it's running in this region. This would be the mediastinum where the heart is contained. So that would make sense that it would innervate the mediastinal, and then the central portion, the diaphragmatic pleura, because as it gets down to the inferior portion and it goes into the diaphragm, it's going to innervate the diaphragmatic pleura. The intercostal nerves makes sense. They're traveling here, in the ribs like this, and around like this. They're going to innervate the costal pleura and then the peripheral portion of the diaphragmatic pleura. So the part of the pleura on the inferior portion that's stretching out this way is going to receive intercostal nerve. Pleuritis, it simply means pleural inflammation. Whenever you see itis at the end, that usually means inflammation. So pericarditis, inflammation of the pericardium, pleuritis, inflammation of the pleura. You get the picture. So again, the nature of the pain in the pleura, it's going to be parietal pleura versus visceral pleura, and it's based again on the difference of innervation. So we have this nice table that we have provide for you in your book here. So we break it down into a pleural layer, type of innervation it receives, and then the nature of the pain. So if you have pain in the visceral area, it's going to be kind of a dull pain in this maybe region right here, versus if you have pleuritis here, it's going to be very localized, sharp pain on this region of the body. Okay, and that's the big difference, and that sometimes can show up on a test question on an anatomy exam. So the pleural space, it's a potential space between the parietal pleura and the visceral pleura, and you can actually see it here in the diagram between these two layers. Key word is it's potential, meaning that usually these two layers are kind of on top of each other. The space is really there. It can accumulate if it has to. It's a site of fluid accumulation in pathological situations. And by definition, a pleural effusion is pathological accumulation of excess fluid in that pleural space. And there's really two types of it, and this is something to be aware of, is the transitate versus the exudate. And the reason why you want to make the distinction is it can indicate the origin or the cause of the pleural effusion. So if you remember, you have your arteries that come in like this, and then you have your capillaries like this, and your capillaries have these small, it's perforated. They have these small holes in them that allow filtration of fluid into the interstitial space. And so what happens is fluid gets filtered out into the capillaries, in and out, and then you have the veins which take it. So in CHF, in congestive heart failure, what you have here is the heart is failing to pump, and so it's gonna the fluid backs up into the pulmonary veins, then it backs up into the pulmonary capillaries, and what you have is an increase in hydrostatic pressure here in the capillaries. And so by having an increase in hydrostatic pressure in the capillaries here, you're going to force more fluid out through these holes. It'd be like, squeezing a bag with a bag of water with perforations in it. The harder you squeeze, meaning the more pressure you apply, the more water you're going to squeeze out. So in this case, it's squeezing out excess amount of serous fluid or fluid from the bloodstream. And because of these perforations, the key difference between transitate and exudate, in transitate process in CHF, the integrity of the capillary wall is still intact. So it's still going to filter, even though it's letting a lot of fluid out. It's still going to filter and not let proteins be, leaked out. It's not going to let other material be leaked out. So it's really just why you get this clear, watery fluid. In most cases, that's indicative of congestive heart failure. So a key difference here is the exudate is actually more a result of processes disrupting the integrity of the capillary wall. So again, the capillaries, they have these nice, small holes in them or perforations, and they allow only, selective, you have an increased amount of pressure, and they only allow selective amounts of fluid to leave, and they contain proteins in. The proteins can't get in through, the perforations are too small. Versus in an exudate, so if we draw a capillary here, the holes become much larger because of, inflammation, pneumonia, malignancy. All these different types of processes can cause damage to the integrity, because it's mainly due to the inflammation coming in here and disrupting the integrity of the capillary wall. So you have these much larger holes in the capillary wall, so then you can have proteins that leak out, cells can leak out, both white cells and blood cells, fluid's going to come out. So it's more that you've cut bigger holes in the capillary than versus congestive heart failure where the pressure's higher. The pressure isn't necessarily higher. It's more that there's more holes and larger holes, allowing more fluid and actually proteins and cells in. And so this is actually more of a non-specific, and if it's an exudate, it gives you an idea that it's not congestive heart failure, but it's some kind of inflammatory process, either pneumonia, malignancy, or some other process. Versus if you have a transudate, it's usually more clear. It's usually due to congestive heart failure. The other thing, a pneumothorax, we're going to talk about this in much more detail. A pneumothorax, by definition, is, a lot of people confuse that. They think it's just simply a collapsed lung. A pneumothorax, by definition, is its accumulation of air in the pleural space. So it's air, instead of fluid accumulating in this space, it's air. So a hemothorax it's accumulation of fluid, but it's accumulation of blood. So you have, hemo, meaning blood, so accumulation of blood in the pleural space, and it's often caused by a laceration of the intercostal artery. So that makes sense. You have these intercostal arteries that travel around in the ribs like this. One of them gets cut, and it bleeds into the pleural space. Then you have a chylothorax, which is accumulation of lymph fluid in this pleural space. So, high triglyceride content, immune cells. This can often be caused by either damage to the lymphatic ducts that are emptying around in the thoracic region that we'll talk about, or some kind of damage to lymphatic vessels causing leakage of lymph fluid, and that can be a cause of a chylothorax. So you have these recesses in the pleural spaces, which are, the first one we'll talk about is the costodiaphragmatic recess, and it's a reflection of the costal. So we have the costal here in green. And then you have the diaphragmatic here in the orange, just over the diaphragm. And it's this space right here where these two, it's like the junction, or the space where these both meet. And it's located laterally and inferiorly, okay? And it's a common place for fluid to accumulate in the pleural space because, gravity pushes down, and then it's an open space here. So fluid can move down this way, it can move down towards it this way. And it's one of the most inferior portions of the pleural space. It's also a good place to do a thoracentesis. A thoracentesis is where you stick a needle through the chest wall into the pleural space to aspirate off that fluid, such as if you're looking to determine if it's a transudate versus an exudate. So you stick a needle in here, and the reason why it's good if you're going to stick a needle in here is versus if you stick a needle, up here, there's a much smaller space and you have a much more increased risk of damaging the lung versus if you stick the needle into the costodiaphragmatic recess, much less chance of decreasing the lung because you have a little bit more space here, as you can see. And so we're going to cut here again to the skeletal model to give you another sense of the three-dimensional aspect, in this case of the costodiaphragmatic recess. So like we said on the last slide, it's the point where the costal pleura located laterally meets with the diaphragmatic pleura inferiorly, so it's a lateral and inferior place. It's not some tiny little, portion right here. It extends all along this entire inferior aspect because the diaphragmatic pleura is going down here inferiorly. Here's the costal pleura, as we've shown you before, represented by the paper. And so that where these two meet would be this portion right here. So that would be your costodiaphragmatic recess. So all along here is that where we were talking about where fluid can collect if it accumulates in the pleural space. And what this is, like we said, is a good place for a thoracentesis, which, because you're going to, by having this space in here, you avoid damaging the lung, which is the last thing you want to do when you do a thoracentesis. So now that we've brought up a thoracentesis, let's talk about what it is. It's a procedure where a needle is inserted into the chest wall to aspirate fluid in the pleural space. Now, the purpose of a thoracentesis is used for diagnostic as well as therapeutic purposes.
Say the patient has a pleural effusion, you'll stick a needle in here, aspirate it out, take the pleural fluid out, then you send it to the lab and you can give you an idea of what is causing it. If it's caused by infection, is it caused by cancer, is it caused by something else? And so what you always want to remember though is that with the thoracentesis, I want to make sure I demonstrate this correctly, is that it is always inserted above the rib. So if we're going to go in this portion right here, we're going to go above the rib like that. And the reason why we do that is because the neurovascular bundle is running in here in the costal groove, or on this rib in the costal groove, just on the interior inferior surface of the rib. So you never want to go on the bottom aspect. If anything, you want to go in the middle or just above the rib like that. Another thing you want to note is that and this is important especially for board exam questions, is that a thoracentesis should be done above the second rib below the upper level of the dullness. So if you find dullness to percussion, where you want to do the thoracentesis is actually you want to count 2 ribs below and go above that second rib. Okay, so we'll show you what we mean by that, because you actually might get asked that. For example, you get a patient, it has a pleural effusion, it's found on physical exam to have dullness to percussion, and it begins at the level of the 5th rib. So here's the 5th rib here, and now we've labeled here in red for you the intercostal spaces. So here's the 5th rib, here's the 5th intercostal space, 4th rib, 4th intercostal space, 3rd rib, and so on. Then down to here, 6th rib, 6th intercostal space, 7th rib, 7 intercostal space. So it has dullness to percussion that begins at the level of the 5th rib. So we want to count down 2 ribs from here. So the 6th rib, 7th rib. Okay, so we want to do it above the 7th rib. 7 is 2 ribs down from 5. And so we'll do it in the 6th intercostal space. Okay, so that's where we'll do the thoracentesis. And when we do the thoracentesis, we're actually going to do it above the 7th rib, because that's going above the 7th rib will then go into the 6th intercostal space. So again, remember, this is the 5th rib, 5th intercostal space, 6th, 7th rib here, go above it into the 6th intercostal space, because you want to get right in the center of whatever's causing this pleural effusion, whatever giving you that dullness to percussion on exam. So for that particular exam question, they would give you a bunch of different scenarios where above or below each certain rib. So the answer would be above the 7th rib into the 6th intercostal space. Another recess we want to talk about here real briefly is the costomediastinal recess. Now this isn't as clinically relevant as high yield as the costodiaphragmatic recess, but we'll still point it out here. So it's on the medial side of the pleura, so it's going to be inside this region right here, okay? And it's better to show you on the 3-dimensional. So what you have here, as we showed here with this paper, is the costal pleura, and then the costal pleura ends here medially, and then it transitions inside the thoracic cage into the mediastinal pleura. So this transition point between all the way down from here, all the way down here, all the way down to here, that transition between the costal pleura up here and then the mediastinal pleura going deep into the medial surface, that is where the costomediastinal recess is.
All right, so to talk more in depth about a pneumothorax, so again, a pneumothorax is an accumulation of air in the pleural space. So we look at this diagram here, we have our lungs on either side, we have our trachea, we have our main bronchi here, and here. You have your parietal pleura here, visceral pleura here, pleural space right here. And so what it is it's accumulation of air in the pleural space here, okay? That's all it is by definition. And you have 3 main types, your open, your spontaneous, and your tension. And one thing to notice between the 2 types, so if we blow this up here, if we have the ribs like this, okay? And then we have the parietal pleura like this, and then we have the visceral pleura like this, and then we have the lung tissue in here. And this is your pleural space. One, you can have breaks in the parietal pleura on the outside that let air in from this way, from the outside. There are also types of pneumothorax where the parietal pleura is just fine, and it's actually the visceral pleura, so it's a break in the lung tissue, and air comes in from this way. So that's an important distinction and concept to understand. So an open pneumothorax, this is the first type. This is kind of your standard, what everyone thinks of when they think of a pneumothorax. It's due to penetrating injury, so a gunshot wound, a stab wound, and it causes a break in the parietal pleura, and we show that here. And what that does is it creates a channel with the outside air. And so what happens is that atmospheric air out here can travel down this pressure gradient into the pleural space here. If you remember, what drives breathing is you have your intrathoracic pressure here, and you have your atmospheric pressure out here. And the atmospheric pressure, when the diaphragm flattens out down here, it descends and flattens, it creates, you know, a negative intrathoracic pressure, and that drives, you know, the air. Because if you remember, air moves from high pressure to low pressure. And so what you've done here is that at first, when you have that first break initially, is the atmospheric pressure is still greater than the intrathoracic pressure. And so, but the problem is as air continues to move in and continues to move in, is that it equalizes. And so it reaches this equilibrium where the atmospheric pressure is equal to the intrathoracic pressure. And then air movement ceases at that point. And so what you've done is you've allowed this equalization. And another point to point out here is the position of the trachea in all these pneumothoraxes. So in this case, since you reach this equalization, there's no deviation of the trachea. It stays in the neutral position here. And one way to treat this is you stick a chest tube in here, and you hook it up to a vacuum, and the vacuum has negative pressure in it, and it sucks the air out. So you suck the air back out, and then you also would surgically fix, you know, this break in the parietal pleura and break in the chest wall. So you fix this, and then you put a chest tube in to drain out, you know, help suck the air out. So a spontaneous pneumothorax, this is an example of where it's a break in the lung parenchyma and the visceral. So it's, you know, it's a break here, and the air leaks out, and it leaks into the pleural space. And then as a result, the lung actually collapses, because it's kind of like letting air out of a balloon. You know, the lung is going to collapse. It's just a bag of air, basically. And so what happens is then air builds up here in the pleural space. Now what's important to note here is that the parietal pleura here is still intact, and it holds the air that's leaked out of the lung in place. You know, the air isn't moving out here into the atmosphere. And so what's important to note about that is that there's certain specific examples that this often happens, and you often see this on an exam, is a classic patient is a patient with emphysema, and that makes sense, right? Because emphysema, you know, trashes the lung tissue. And so what happens is you have weakened walls in the lung parenchyma, and you have these breaks, and, you know, air ends up leaking out and causing a spontaneous pneumothorax. Another common example is a tall, thin, young male. And then as a result, as we'll talk about the position of the trachea. So if you remember the neutral position, the trachea is now deviated this way towards the pneumothorax. If you were to get an x-ray in this patient, this is what you see. And the way I like to think about this and remember this is that the lung has become smaller, and so the trachea almost falls towards the lung. It falls towards the empty lung here, the empty space. And that's the way I like to remember how the trachea deviates towards the pneumothorax versus away or in the neutral position. And then lastly here, we'll talk about a tension pneumothorax. So this is a break in the parietal pleura, and you can see that right here. And so if we blow this up, you know, this is your parietal pleura here, and then this is the break right here. Here's the visceral pleura here. Again, it's a type of open pneumothorax because you have a penetrating trauma, breaks the parietal pleura, allows air to flow from the outside world. And so this torn segment here, it acts like a valve. You know, it opens and closes. And what happens is that it allows air to come in during inspiration, but then the valve closes during expiration. So it with each breath, you're essentially, you know, pumping more air into the pleural space here. And so since it doesn't let any air out during expiration, as you breathe and breathe and breathe, each breath you take, you're accumulating more air. And what happens is that this area continues to expand and expand and expand and continue to press on the lung and compress the lung. And so it's analogous to if you were to, you know, pump air into a tire. So each time you pump the pump that's hooked up to a tire, you're pumping air in and not letting any air out. Same concept here. This valve that's created by a tear in the pleura, you know, it allows air with each breath. Each time the person breathes, they're accumulating more and more air. And so this is a very dangerous injury to have. So again, the common cause of this is victims of stab wounds or other penetrating trauma. And then as far as the position of the trachea is, you know, since, you know, you let all this air in and it continues to expand and expand and expand, is it's, you know, the way I like to think about it is the pleural space continues to expand and push the lung and push the lung and push the lung this way. So eventually you're pushing the lung this way, and then you push the trachea away from the pneumothorax.
Now, one thing we want to point out here with pneumothoraxes is that actually the cupula, due to the fact that it extends above the first rib and into the neck, that actually puts the pleura at increased risk for injury when there's an injury to the neck region. And so, for example, if someone were unfortunately get stabbed in the neck region like this, that's going to go right through, you know, even though it's avoiding the rib cage, it's going to go right through that cupula. and that can lead to a tension pneumothorax in the left lung.
So we're just going to go over this high-yield x-ray right here. This is something you could very easily see on a board exam or an anatomy exam. So this is an AP x-ray of a tension pneumothorax. And so what we'll show here is this is the right side, this is the left side. And if you look at, this is normal lung here on the left side. You see these kind of stringy, whitish looking structures here. This is just the normal lung parenchyma, the normal appearance of the lung on x-ray. Versus if you look over here in this portion that I'm going to outline here, it's very clear. There's none of this, stringy, whitish looking structures here. And the reason for that is this is where the pneumothorax is. So this is, there's been some kind of trauma or penetration here, allowing air to continuously accumulate with each breath. Remember, you have that valve structure like this, in which with each breath it comes in. And so you've had this air accumulate in the pleural space here, and it's really compressed down on the right lung. And so this is the right lung tissue. It's pretty severely compressed, as you can see here. It's actually so severely compressed that you can see where it's pushing on the mediastinum, which would be in here, and the outline of the heart here is actually pushed more so to the left than it normally would, and that's indicated by the black arrow here. And then as a result of also pushing on the lung, and then the trachea would normally run here. So this is, you can see these kind of blocks stack here. This would be the vertebral column. Normally the trachea kind of runs just anterior to the vertebral column on this x-ray. And what you'll notice here is indicated by the red arrow is this kind of this faint outline here, is the trachea has been deviated away from the pneumothorax or to the left side. And so again, that's a hallmark of the tension pneumothorax. So we're showing this just so you can get a good look at, practice reading chest x-rays and reading a very important pathology on x-ray. And that concludes our discussion of pneumothoraxes, and it concludes our discussion of the pleura.